Hey guys, let us simplify the topic of anti-clotting agents today. So many people have requested me to simplify this topic. I have drawn three flowcharts in one single sheet so that you can easily understand the clotting process first, and then let us enter into the drugs. Okay, so firstly, for a clot to be formed, platelets are required, coagulation factors are required, and fibrinogen is required. So platelets, coagulation factors and fibrinogen together form the clots. So anti-clotting factors may be the ones which inhibit the process of formation of the clot or which breaks down the clot, right? So which causes the clot lysis are also called as anti-clotting agents. So the one such example is fibrinolytics. Remember that point. So now let us learn about the anti-platelet agents, or as such the platelet pathway first. So when the blood vessel is injured, the collagen and von Willebrand factor gets attracted to the damaged area and they activate the platelets. So the platelets in return increases four different pathways or acts on four different pathways, you remember like that. So they are GP2B3A increases the thromboxane A2 or increases adenosine diphosphate or increases the phospholipids. So these four pathways are via which platelets act. So GP2B3A increases platelet aggregation. Thromboxane A2 acts on thromboxane A2 receptor. ADP acts on P2Y12 receptor. Both together increases the platelet aggregation. Phospholipids increases the coagulation system, increases the thrombin, which acts on PAR receptor, and finally all this together increases the platelet aggregation, leading to the formation of the platelet clot. Okay, thrombin is factor 2A. It converts fibrinogen to fibrin and it stabilizes the clot. So finally the clot is formed. This is the pathway, right? So this is the pathway which happens naturally for a clot to be formed. So now we have the drugs which acts on individual areas of this pathway. Let us learn them. So first one being GP2B3A inhibitors. So these acts on the platelet aggregation by inhibiting the receptors of GP2B3A. So B and A is there in GP2B3A. So all the drugs have AB letters in it. Abciximab, tirofiban and eptifibatate. BA in everything. Coming to thromboxane A2. So aspirin is the drug which decreases the formation of thromboxane A2. It does not act on the receptor, but it decreases the formation of thromboxane A2. So as all of us know, amino acid pathway, that is arachnoid acid pathway, has both COX and LOX, right? COX pathway and LOX pathway. So when aspirin inhibits the COX pathway, all the intermediates gets converted into the LOX pathway. So that forms increased leukotriene formation will be there. So when there is increased leukotriene formation, the hypersensitivity reactions increases and asthma might also occur. So overreactivity will be there in that person. So a person who is on aspirin is more prone to hypersensitivity, increased hypersensitivity reactions due to increased leukotrienes. So this is an important point that you need to remember. Aspirin decreases the formation of thromboxane A2. Thromboxane A2 is the final product or the intermediate of arachnoidic acid pathway, that is steroid synthesis pathway. Now coming to the third one, that is P2Y12 receptor agents. So there are few agents which block P2Y12 receptors. In that also they are irreversible and reversible. So coming to irreversible ones, irreversible means something which is for long term, something which is for permanent. So all the drugs have P letter in it: clopidogrel, prasugrel, anticlopidine. So P letter is there because irreversible is permanent. When you compare it with the reversible ones, there is no P letter in the reversible drugs. That cangrelor and ticagrelor is not having P in it. In reversible drugs have R in it. Cangrelor and ticagrelor has R in it, whereas permanent or irreversible ones has P in it. So cangrelor, C for C, it is competitive. Ticagrelor is non-competitive drug. So you need to remember all the drugs that are involved in the anti-platelet agents, which are a part of whole umbrella anti-clotting agents, right? Now let us try to understand the clotting cascade so that you can easily understand the anticoagulant agents now. So the clotting cascade has two pathways, as all of us know, that is intrinsic and extrinsic. So intrinsic pathway, the factors that are involved are 12, 11, 9, whereas extrinsic it is 7 and 3. 12 has T in it, 11 starts with E and 9 starts with 9. So TEN for the intrinsic pathway, whereas extrinsic pathway has 7 and 3 factors. 7 plus 3 together constitutes 10 again. So remember the mnemonic 10 here. TEN and 10 finally activates the factor 10. So this factor 10 now converts prothrombin to thrombin, and this thrombin converts fibrinogen to fibrin. Finally cross-linking happens and that forms the clot. So this is the clotting pathway. Now the anticoagulant agents acts on different parts of this clotting pathway to stop the formation of the clot. So let us discuss about the anticoagulation agents in detail now. When we discuss about the anti-clotting agents, we have completed the discussion of antiplatelet drugs, but I have missed a drug, Warfarin here. It acts on the PAR receptor. Okay, Warfarin acts on the PAR receptor. So you can see there PAR is there in the word Warfarin also in reverse, PAR. So this is also a drug. This is the fourth drug which comes under the antiplatelet agents. The full form of PAR is protease activating receptor. Just remember this point that Warfarin is one of the drug. There's no lot of importance, but just remember the drug name. So here comes the antiplatelet. When we discuss about the ticlopidin here, that is the most toxic agent in P2Y12 receptor blockers. Ticlopidin is the most toxic agent. So now let us go to the coagulation process. As I have already discussed in the previous diagram, intrinsic and extrinsic pathways, let us discuss from the factor 10 zone, right, the common pathway zone. So 10 is converted to 10A, that converts thrombin, that is factor 2 to 2A, and this 2A converts fibrinogen to fibrin. So finally the fibrin is formed and it forms cross-linkings and it forms the clot. So the drugs which acts on this coagulation process are anticoagulants, and the drugs that act on platelets are antiplatelets. So you need to have this thing very clear in the mind, that aspirin is an antiplatelet, whereas warfarin, heparin and all are anticoagulants. Okay, so this is the flowchart showing anticoagulants in detail. This is the beautiful flowchart. You need to remember all the drugs in this flowchart, and I'll try to make this simple. So anticoagulants now divided into oral drugs and parenteral drugs, right? So again these oral and parenteral are divided into two different sections, that is indirect thrombin inhibitors, direct thrombin. Parenteral also have indirect and direct thrombin. Oral has an extra thing, that is factor 10A inhibitors also, right? So when we discuss about, this thrombin is factor 2. Now coming to direct thrombin inhibitors and factor 10A inhibitors, these two together are called as NOAC or DOAC, that is novel orally acting coagulation agents, or DOAC, directly acting ones, NOAC and DOAC. Okay, this is an important point. Direct thrombin inhibitors and factor 10A inhibitors together constitute NOAC or DOAC. Now coming to indirect thrombin inhibitors are actually vitamin K inhibitors. The important hero of this entire story is Warfarin. Warfarin is the first hero and Heparin is the second. Okay, so now let us discuss about first one. Warfarin comes under indirect thrombin. Second one is direct thrombin inhibitors. Those are dabigatran and zimalgatran. When there is warfarin toxicity, that is overdose of warfarin, there occurs a lot of bleeding, right? So for that we need to use an antidote, which is vitamin K. Whereas for dabigatran, the overdose, the antidote is idarucizumab. Dabigatran has DA and idarucizumab also has DA. I have highlighted there. When we talk about factor 10A inhibitors, and the toxicity caused by factor 10A inhibitors is treated by endoxanate alpha, and the drugs also have XA in it. Antidote also has XA in it. Endoxanate alpha is an antidote, whereas rivaroxaban, apixaban, batrixaban are the drugs. So all the examples that come under oral anticoagulants are done. So warfarin is an oral anticoagulant. Make it clear here itself. Now when we discuss about pathway on which warfarin acts, vitamin K is converted into its active form by vitamin K epoxide reductase, that is VCOR. This vitamin K now causes gamma carboxylation, which is an important question. They might ask you alpha, beta or gamma carboxylation. It is gamma carboxylation. This gamma carboxylation is of the factors. What are those factors means? 2, 7, 9, 10 and protein C and protein S. This warfarin inhibits the VCOR enzyme. So this entire thing does not happen. Gamma carboxylation does not happen. So all the factors decrease. That is protein CS decreases, 2, 7, 9, 10 also decreases. So let us go towards the parenteral now. Parenteral also have indirect and direct. So the word parenteral has PAR in it, PAR, and indirect is IN. So all the drugs that are parenteral and indirect actants are parins: heparin, enoxaparin, dalteparin, and so on. So every word has parin in it: parenteral, indirect. So when we discuss about heparin, it is unfractionated heparin, whereas the next three drugs, that is enoxaparin, dalteparin, and tinzaparin, are low molecular weight ones. Fondaparinux and idraparinux are the synthetic ones. These are the longest acting ones. These are given subcutaneously. So this completes the parenterally acting indirect anticoagulants. When we discuss about the direct ones has D in it, DIN. So hirudin, lepirudin, bivalirudin. Okay, so these three are having DIN in it. Now the last one, argatroban, is something different. It is a different name. Just remember that point, argatroban. The first three drugs are bivalent, whereas argatroban is monovalent. So the letter A is first, right? So mono. A is one, monovalent agent. Whereas hirudin, lepirudin, and bivalirudin are bivalent. So anticoagulants is done now. Remember the gamma carboxylation point. So when we discuss about the warfarin in detail, it acts on weak or enzyme, right? It inhibits the weak or enzyme. So it decreases all the factors, right? So protein C and protein S are also one of the factors that gets decreased. Actually, the function of protein C and protein S is to decrease the clot. Okay, protein C and protein S are the anti-clotting agents, whereas 2, 7, 9, 10 are the general coagulation factors which are involved in the coagulation cascade forming clotting. So since the anti-clotting agents are decreased, that will finally lead to increased clotting. So protein C and protein S are anti-clotting agents, they are decreased. So clotting increases. This leads to purple toe syndrome. I'm stressing on this point because this is a recent exam question also. There was an image which showed purple toe syndrome and they asked about the drug causing it. Okay, purple toe syndrome, that is dermal vascular necrosis caused by warfarin in the initial days of its usage. And coming to the teratogenic activity of warfarin, this is also an important question. It causes nasal hypoplasia and stipple calcification, and the syndrome that it causes is called as Conradi-Hanerman syndrome. So this takes us to the important part, when to use warfarin in pregnancy, because it is teratogenic, right? So up to 12 weeks you should not use warfarin because that is embryogenesis, that is organogenesis phase, right? So you should not use warfarin because it causes stipple calcification. So up to 12 weeks make use of heparin. From 12 to 36 weeks, that is during the second trimester region, you can use warfarin, and from 36 weeks again you have to shift it towards heparin, warfarin, and heparin. So when a patient is on warfarin, so INR monitoring plays an important role. So INR monitoring, based on the monitoring of INR, we need to increase or decrease the dose of warfarin, or we need to stop the drug. So the normal INR is 2 to 3. When the INR value goes to beyond 3, that is 3 to 10, we need to stop warfarin and restart the warfarin when INR normalizes. When it is greater than 10 and the patient is asymptomatic, that is there are no features of bleeding, there is no gum bleeding or something like that, then the drug of choice is oral vitamin K, and we need to stop warfarin and restart when the INR is normal, same like the first case. But when the patient is symptomatic, there are features of bleeding at any INR. It might even be normal INR or abnormal INR. If the patient is symptomatic, just start fresh frozen plasma. So the drug of choice is fresh frozen plasma. When we discuss about the conditions in which warfarin is used as drug of choice, there are three: mechanical valve thrombosis, APLA, and splanchnic vein thrombosis. Here in NOAC and DOAC, these are contraindicated in mechanical valve conditions like mechanical valve atrial fibrillation or something like that. But in those conditions, warfarin is the drug of choice. So you need to remember these both points. This completes the important points regarding warfarin, which is given orally, whereas heparin is given parenterally, right? Heparin comes under parin, parenterally, indirect acting heparin, oral is warfarin. The difference is important here. Now when we discuss about heparin, that is parenterally acting indirect drug. Heparin, there are three types of heparin, right? Unfractionated, low molecular weight, and synthetic one, that is fondaparinux. This fondaparinux synthetic one is given subcutaneously and it is the longest acting one. When we talk about the heparin, the structure of heparin has a pentasaccharide unit, this is the active unit, and a polysaccharide unit, heteropolysaccharide unit, which is the longest one. So every heparin has pentasaccharide unit in common. Even fondaparinux also has pentasaccharide. Whereas low molecular, that means low, that is small size of polysaccharide, whereas fondaparinux never have this heteropolysaccharide unit only. It only has that active pentasaccharide unit. So the pentasaccharide unit is the active one. It binds to antithrombin 3, activates it, and it breaks the factor 10A. So this holds same for all the three drugs. So this pathway is same. Whereas unfractionated heparin has heteropolysaccharide, it binds to factor 2A. Low molecular also has heteropolysaccharide, but it binds to less amount of factor 2A. So the action is mainly on 10A greater than 2A. Whereas fondaparinux, it's only on 10A because there is no heteropolysaccharide unit here. Coming to the metabolism point, unfractionated heparin is by reticuloendothelial system, whereas low and fonda are from kidney, excreted via kidney. So in kidney failure patients, UFH can be given safely. Whereas in kidney failure patients, these drugs, that is low molecular weight heparin and fondaparinux, needs to be monitored. Coming to the antidote discussion, protamine sulfate can be used as a perfect antidote for unfractionated heparin. For low molecular weight heparin, it might not be considered as a drug of choice antidote, but it can be used still because there is heteropolysaccharide unit. But in fondaparinux, protamine sulfate does not play any role. When we enter into the discussion of heteropolysaccharide actually what happens is it binds to an antibody. It cross reacts with heteropolysaccharide. Antibody cross reacts with heteropolysaccharide. These both together activates platelet factor 4. This platelet factor 4 increases the aggregation of the platelets, that is the thrombus formation, aggregation of the platelets. That leads to the formation of thrombus and heparin induced thrombocytopenia, right? Heparin induced thrombocytopenia. That is an important question. So they ask you, what is the drug that you use to treat heparin induced thrombocytopenia, or when you suspect heparin induced thrombocytopenia? So that drug that we use is ergotroban. So just try to recall ergotroban we have read under parenteral drugs. In the parenteral drugs also we have read it under direct one along with hirudin, lepirudin, bevalirudin, ergotroban monovalent one. So it is a drug of choice for heparin induced thrombocytopenia. Yes, so this completes the anticoagulant, and we have done antiplatelets also. So heparin is also done. Now let us discuss a small part of monitoring. Okay, so there are few agents which require monitoring and few which does not require. So not required is for low molecular weight heparin and fondaparinux. Just write above in that table low molecular and fondaparinux. And DOAC, NOAC also does not require any monitoring. Whereas monitoring is required for unfractionated heparin, warfarin, the direct acting ones, hirudin, lepirudin, and ergotroban. So for unfractionated heparin, remember it as HINT. Okay, so that is HINT means intrinsic pathway, so APTT. Whereas warfarin is for WEPT, that is PT. Warfarin we need to monitor PT, whereas for heparin, since it acts on the intrinsic pathway, we need to monitor APTT. And hirudin and ergotroban also requires monitoring. Just remember these points. Not required for LMWH, fondaparinux, DOAC or NOAC. Now coming to the discussion of fibrinolytics. Okay, fibrinolytics are the third drugs that comes under anti-clotting agents. So antiplatelets is done, anticoagulants is done, and the last table chota box is left over, that is regarding fibrinolytics. So this plasminogen is getting activated into plasmin by tissue plasminogen activator. This plasmin breaks the fibrin. Okay, so there are non-specific and clot-specific drugs here. Non-specific ones are streptokinase, urokinase, and clot-specific are DART, dutyplase, altiplase, retiplase, and tenecteplase. Okay, tenecteplase is the longest acting one. So these non-specific and specific drugs are tissue plasminogen activator analogs. That means they activate the TPA, or they act like TPA, tissue plasminogen activator. So these both drugs are activators. I have written minus symbol there, sorry, that's my mistake. It is actually a plus. Okay, those are analogs, those are TPA analogs. So TPA analogs are otherwise called as fibrinolytics, right? Non-specific and specific as already discussed. So what does they do? They break the clot. So there is an increased risk of bleeding. So to treat this bleeding, we have two more drugs. These two more drugs, that is EACA and tranexamic, are not fibrinolytics. They are the treatment that we used for fibrinolytic toxicity or the bleeding that is caused by fibrinolytics. So these are anti-fibrinolytics. Okay. EACA is epsilon amino caproic acid. This tranexamic acid is approved particularly for postpartum hemorrhage. Okay. Tranexamic is for postpartum hemorrhage. These two drugs are anti-fibrinolytics. The above drugs, that is strepto, uro, dutyplase, and all are fibrinolytics. Fibrinolytics are TPA analogs. Okay. Just change one symbol there. I have written negative. They are actually the TPA analogs. They are not negative. It should be the positive symbol. Just make that small correction. So if you like the content like this, please like, share and subscribe, and put your doubts or any topic of interest in the comment section below or in the Telegram group. Thank you.